Hello, today we're going to be taking a look at the Alphabyte digital scanner for preformed pediatric zirconia crowns. What is Alphabyte? Alphabyte is a technology that allows the provider to size and help with the preparation of preformed pediatric zirconia crowns. One of the first few questions that I would want to answer is one, are preformed pediatric zirconia crowns equal to or better than existing restorative treatment options? And two, is a technology like this needed, or has it been demonstrated for a need or a beneficial need over what we're currently doing for preformed pediatric zirconia crowns? Many of the existing preformed zirconia versus composite strip crown studies aren't extremely longitudinal, but a lot of the studies have shown that preformed pediatric zirconia crowns are equal to or slightly better performance than composite strip crowns. And this would make sense on the high caries risk child that we would tend to use these restorations on as a full coverage for multi-surface or heavily carious anterior teeth and the high risk child with a high likelihood of caries reoccurrence and progression. My next question when looking through the literature is there anything that examines the challenges in adapting preformed pediatric zirconia crowns into a program that is already doing other restorative techniques for these teeth? I think this is a great study. It is a thesis and dissertation from UCSF that actually delves into this. And the reason why I like it so much is they actually talk about some of the negative outcomes and some of the learning factors that they had to garner when starting this at their program. And I always kind of come back to this study when I am looking at introducing new technologies, new techniques, new theories, or new treatments into an office or practice, because I think it sheds a lot of light on the negatives and the positives of doing things like that. One of the most interesting findings that I think is that at 36 months, their survival analysis had pediatric preformed zirconia crowns at 35%. That is not a great number when it comes to survivorship. And if we were introducing any kind of therapy, whether it's a pulp therapy or a new restorative material or a new technique, and we only found a 35% success rate at 3 years, that would probably be something we would want to abandon or not recommend. And what I thought was really interesting is comparison to strip crowns or stainless steel crowns. And they actually dove into the factors why they thought those weren't successful. So looking at the distribution of causes of failure for the preformed pediatric zirconia crowns, we can see that the larger amount are abscess, 42%, missing crowns, 25%, and fractured crowns, 25%. And you can actually kind of look at and they explore the technique and the preparation and the sensitivity of cementing those crowns and why they thought it was at that level. In my opinion, preformed pediatric zirconia crowns do have a pretty difficult upstart as far as the knowledge. Over preparation, over tapering, lack of a sufficient occlusal reduction, or over tapering the occlusal portion while leaving a wider base can lead to fractured crowns, can lead to abscesses with incidental pulp exposures, and can also lead to missing crowns with over tapering, reducing the resistance and retention form of the crown since they're mostly cement retained. Another interesting part of this study is the distribution of causes of failure of resin composite strip crowns, which include abscess, fracture, and recurring caries. Now this, in my opinion, makes sense because a lot of the times we're doing these treatments on children who have high caries risk, severe early childhood caries, high caries risk behaviors, and that have anterior multi-surface restorations. A lot of the current research supports that the treatment that we do on children is certainly not definitive. And the high caries risk child that we put these restorations on, a large majority of them probably still remain high caries risk. So the thing that we need to examine is there a restoration that has the longitudinality of also protecting the circumferential portions of those teeth and preventing recurrent caries. This is an example of the patient that I'm referring to who maybe previously had full coverage resins or multi-surface resins that still remains high risk and presents to your office for periodic recall, or they don't have great follow-up and then present to your office for limited oral evaluation for pain. You can appreciate that the habits that caused the caries in the first place probably didn't change. And similar to a stainless steel crown, is there a procedure that we can offer that's not resin based that'll allow more longitudinality? The last question I'd want to look at is, does there exist a study that examines a technology similar to Alphabyte that shows successful use and a benefit of use in newer pediatric preformed zirconia crown users? This study out of Korea used a technology very similar and a process very similar to Alphabyte, and I thought it was interesting because it isn't Alphabyte or any of its proprietary software. This study found that when novice users utilized this technology, they had overall less tooth reduction and shorter tooth preparation times. They also found that their preparations were more harmonious than when compared to not using the software. Now this is beneficial because it does address a lot of the key points of the previous study from UCSF and shows that with guided techniques, a novice user can more quickly or more assertively master preformed pediatric zirconia crowns. So let's go ahead and dive into an Alphabyte case. This is going to be on tooth number E as in Edward and F as in Franklin. We're going to select our tooth form, tooth number E. We're going to launch the Alphabyte module, and then we're going to scan that section of tooth. So you can see that number E is selected, and that is going to be the tooth that we're going to scan for. When I've been scanning these, I've just been doing the sextant. I think you would be okay to scan one tooth in front and one tooth behind of the software. I find that it doesn't take a long time to actually physically scan this area. The downside to intraoral scanners, regardless of the brand, is they can be a little large in the pediatric mouth. But here we are, we finished scanning. This is our 3D representation of the area, and I just think it's kind of cool. We can zoom in and look at the decay. You can look at the occlusal wear pattern, the gingival incisal heights, mesial distal dimensions. It's also just kind of interesting. So our next step would be to actually launch the Alphabyte program. So we're going to select our target tooth. We're going to want to try to size a crown for tooth number E as in Edward. So what happens next is the computer kind of shows an ideal pediatric zirconia crown. Now, what we have to do as the user is adjust and kind of just quickly align over where that ideal crown should be. Now, in a practice setting, a trained assistant, after you anesthetize or after the patient is seated, could scan the patient and do this portion for you. I'm just kind of showing there is a little guided wizard that walks you through each step. Once you master this, it really doesn't take that long to do. A few clicks and you can get to the right point. So here I am kind of aligning the ideal crown over the correct occlusal incisal line angles and to make it match the adjacent occlusal teeth. And I think the most important part here is I'm actually adjusting the mesial distal dimensions to get the right crown selection. One of the interesting things in the right hand side is that reduction guideline. I think that's also very helpful when you're looking at the amount of reduction that needs to occur. And here I'm just kind of messing around and showing how you can move the crown in 3 dimensions. Typically it doesn't take this long to show. I'm just kind of showing you guys the features of the software. So we're happy with our crown size. We're going to hit accept. And one of the things that I also wanted to show is if you can kind of look in where it says crown size, it's showing a C4, but those little kind of aquamarine lines, I really think we need to move it a little bit over to the mesio and distal line angle, so you can kind of appreciate as I adjust that it decreases the ideal crown size. Typically when I do these cases, I like that aquamarine line just to be touching the mesial and distal dimensions. You can see as I move it a little too far past where those line angles would be, it showed me a C2, but I'm pretty happy with this and I got to that C3 size. So what's really nice here is we have this reduction guide that kind of helps new users guide themselves in the process. And I still use this as well after I scan the tooth to look at how much reduction I do or do not need to do. If you appreciate the lingual side, the more blue or green color shows less reduction. And if you look around the circumferential area towards the gingival margin, it shows a heavier reduction, especially at the line angles where these preps tend to get you caught up at and where it's more difficult to seat these crowns. One thing I've also been doing is if I'm prepping E and F, I would assume, and as long as I'm looking at the tooth, that would be a pretty similar size. So for F, I actually also used a C3. I've been finding that beneficial from when I'm prepping the D's and when I'm prepping the E's, that I tend to find the size that I initially scanned with is very similar to the other crown sizes as well. So in the end, this is my final case. Here's E and here's F cemented. And I was very happy with the aesthetic results in the ease in the crown selection, and also that the preparation guideline really did actually keep my preps more conservative and gave me a better idea. And I really think that's going to add to the resistance and retention form of the crown to really maximize that, to minimize the negative outcomes that the UCSF study pointed out that can be difficult about these crowns. So what do I think about Alphabyte? I have done posterior and anterior cases. I found that it was actually pretty beneficial knowing the crown sizes, and once you get the initial crown sizing and formatting down, I found that every single time it picked the correct crown, and it also helped me with the reduction guideline do more minimal, more conservative preparations. I think Alphabyte is beneficial for academic programs or for private practices or offices who have new pediatric preformed zirconia crown users or general practice practitioners who would be interested in utilizing preformed zirconia crowns. One of the things I like to say is we usually get things last. MTA came last, zirconia crowns came last. When I was at AAPD last year, when I've just been kind of looking at the course content coming out, 3D digital workflow is definitely making its way into pediatric dentistry, so I think we're kind of at the forefront of this technology, and I'm just excited to see how it can be used by practices and in the future.